Now, we've got high cost of oncology drug regimens. We've got payers that are analyzing various models to maintain quality of care, right? Everybody wants this. These include providing incentives to physicians for following certain clinical pathways or bundled payment, right, instead of episodic payment. So the first question that comes up is, what are the criteria that determine acceptance of a clinical pathway by a provider? And what would prevent a provider from implementing a pathway all by his or herself? What do you think?
Well, I think that for a provider not to want to use a pathway, it's got to be a major departure from what they're already doing, and it's not found in evidence-based. In other words, it's an arbitrary and capricious pathway development.
So you're saying a provider says, I feel this is a good idea in my vast clinical experience. And by the way, have you all had interns say this to you? In my experience. It's pretty bizarre. But supposing a mature provider says, in my experience, this is the way to go. The heck with your pathway. I'm going to have a new pathway.
Well, I want to see what his pathway is and what he's actually proposing to use. I mean, for instance, in breast cancer, as somebody alluded to earlier, there's an infinite number of acceptable methodologies and acceptable adjuvant modalities and combinations. It's a question of matching it for that individual patient, looking at toxicity, efficacy first, obviously, toxicity second, and cost third. And if he or she, the healthcare provider involved, is totally against that and wants to use something totally against NCCN ASCO guidelines and evidence-based methodology, there's little that you or I are going to do to change that guy's thinking.
Oh, but isn't there?
Oh, there is.
Oh, sure there is. It's like,
because we're the
we're
insurance.
not paying you for it.
That's a very difficult situation to get into.
He doesn't think so.
No, I mean, I agree with Irving in some of what he says, but I think our role is to translate clinical information into financially prudent coverage.
Okay.
And if people do not want to adhere to a gold standard of evidence, they have to have a pretty compelling reason why. And there may be reasons why, but it would not be something we would just auto-pay.
All right, we're going to jump to Dr. Sweeney for a minute.
Institutions, and even at the clinician level, we all want to deliver the best therapy that we can. And oftentimes it's difficult to make a decision with lack of data or conflicting data sets. So consensus guidelines are a very important and helpful way of guiding physicians. And I know, for example, at Dana-Farber Cancer Institute, we've put pathways together and they provide guidance for clinicians when they're seeing a patient in front of them to think about what is the best treatment for that patient at that part of their cancer journey. So pathways are an extremely helpful and facilitative way to get the right treatment to the right patient at the right time.
All right, well then we're talking about payers developing pathways or endorsing pathways. So how do you use pre-existing data to establish this if you're a payer?
How do you use pre-existing data? Well, first of all, in looking at the pathway development, you can buy, as a payer, you can buy pathways. There are companies out there that are selling their pathways.
You mean the American Pathway Company?
You betcha. You can work with companies who've got a template and then work with providers to augment those pathways. Or in the case of our health plan, what we've done is gone to individual provider groups and say, you tell us what in your experience is best and we'll hold you accountable to that. And we found that that works best because we don't have to have collaboration amongst 50 provider groups across the state. So there are multiple different mechanisms
so you're
for
looking
establishing pathways.
In other words, the docs to give you input, then you'll roll it back and say, well, pay for that provided you stick to it. Is that what I'm hearing?
Yeah. With enough latitude that when there are individual patient considerations, so if you've got a violinist who has cancer and they can't take a neuropathic or neurotoxic therapy, yeah, there is a variation that's allowable, sure.
Go ahead.
No, I was just going to acknowledge that there is some variation, and there's some variation in the approach. If you're interested in putting patient interests first with pathways, you can say, okay, so we want the most effective, least toxic, and then if there is a least costly alternative, fine. So you can approach it that way. You can also approach it with if there's an acceptable quality threshold, then that's what we'll pay for. So in coming to it, you can get to different places, but again, as we start off from any of the compendia, you've got a fairly broad highway of choices.
But you can hear, in response to that second pathway, you can hear the howls now, right? Yes, it's more expensive, but my mom has an expectation that if she does this, she might get an extra year, an extra 2 years. I want the best.
And I would agree with you. We want to give the best that we can. But the fact of the matter is that there are instances where we don't have a lot of choices. And we're starting to see that now. We're getting to places where we're getting some very effective drugs where there is very little competition at an extraordinary price.
As you think about what pathways bring to the table, there are two major benefits of pathways programs. The first is it requires the establishment of process for evaluating efficacy and toxicity. Same set of rules.
You mean you want data?
Transparent.
Right.
And the second thing it does is it allows you to measure performance. So this is a generational thing to some extent. But the fact of the matter is we should be comfortable with the idea that a physician's performance should be measurable. And a pathways program, at least for me, is not a pathways program unless you can measure performance.